Okay, today we are here with Dr. Kimberly Hiroto, who is a clinical geropsychologist for VA Palo Alto in the hospice and palliative care department. So, Kim, thank you for joining us. I appreciate you being here. We have a lot of interest actually in the class and in sort of end of life issues in care in hospice and palliative care. So this will be a really fun discussion for us to have and for them to learn from you. Thank you.
Oh, thank you for having me.
So the first question I'm going to ask is, could you tell us about what you do every day as a clinical geropsychologist and how that relates to aging?
Sure. So I work in a hospital setting. So I work in an inpatient hospital setting. And I mainly will provide direct care services, so psychotherapy, to our veterans here who are either living with life-limiting illnesses in hospice, so which means they basically are determined to have 6 months or less of time remaining. Our unit here is actually an acute inpatient hospice, and so that means that patients are living with illnesses and with symptoms that exceed what normally can be managed at home or in other residential facility settings. Maybe, terrible wounds or psychiatric conditions, lack of support at home, other factors that make, pain crisis, other factors that make it really hard to manage their illness and their symptoms at home without 24/7 care.
Mm-hmm.
I also work in our nursing home setting, which the VA calls our community living center. And so there it's a short stay rehab setting. So it's with largely older adult veterans who are recovering from things like amputation or preparing for amputation, receiving dialysis, chemotherapy, and are generally quite ill. So they're really functionally quite low in terms of physical functioning, sometimes cognitive functioning as well.
Mm-hmm.
But they're here for short stay rehab and often then discharge either back to another community living center or nursing home, or sometimes their physical home. And sometimes they go home with home hospice as well. So while they're not at end of life, they also aren't super, super healthy.
Right.
And so a lot of the work there involves adjustment to illness, adjustment to functional decline, adjustment to new diagnoses or upcoming amputations and life-changing, catastrophic changes in life, along with more common things like post-traumatic stress disorder, anxiety, depression, sometimes suicidality, substance use, and then also supporting their families as well, especially during this time of COVID. I'm glad to talk a bit about the hospice side in terms of the work, but I want to
yeah, go ahead. No, that'd be great. I think that it would be a good insight and a window into what that type of care is like for us.
Sure. So on the hospice side, a lot of the work is around helping our veterans or facilitating discussions around what their end of life may look like, helping to address themes like existential distress. So it might come out as sounding like, what did my life mean? Why am I sick now? Why is this happening to me now? Is this retribution for past sins? On the flip side, it can also sound like, why haven't I died yet? Right? I'm lingering, I'm waiting for death, I'm ready for it, and it's not coming yet, and why not? And I can't stand the waiting process and just kind of that waiting for that moment to be taken. I'm waiting with bated breath, and I'm ready for it, and why isn't it coming yet? There also can be symptoms of things like post-traumatic stress disorder, anxiety, depression, sometimes suicidality as well at end of life, and it can reemerge as well under stressors. And so if we think about a person who survived,
Oh, we lost for a second. I'm sure we'll be back. All right. Okay, so we're back, and you were telling us about what kind of clinical presentations you typically get in hospice, and I think we stopped somewhere around PTSD.
Yeah, thank you. So I was just saying that I think, when we think about anyone, in particular veterans, though, who might have faced life-threatening situations in combat or in other settings in life, and now they're facing another time in which their life is threatened by illness, that can really trigger re-traumatization, as well as feelings of vulnerability, helplessness, fear, um, as well as worries or lack of control, right? So those types of emotions and sensations and feelings can also then trigger reemergence of PTSD.
Hmm.
In addition, I think what we also see once in a while is themes of moral injury, especially around veterans who might be reflecting on their life, or individuals or who might be reflecting on their life and thinking about the events, the activities, the things they did in their life that might have violated their morals, their values. And moral injury often takes the form of, it's in the context of killing among veterans in combat.
Mm-hmm.
But I think it also plays out in other forms around violating religious beliefs, violating other forms of values. It doesn't have to be as extreme as killing, but it could
Right.
be other things of, not stepping in to help someone in need, not saying something when they saw someone being victimized or being harmed in some way.
Mm-hmm.
And so those, deeper existential and personal struggles can also come through as well at end of life. Um, and so then we also take care of the family unit here as well. So that includes supporting the families and friends, especially when people can't visit as easily right now during COVID,
Oh, yeah.
and helping them with things like anticipatory grief and helping to prevent things like complicated grief from happening if we see risk factors present. So.
That's quite a lot of work. I think that sometimes, we try to expand their ideas here in class. Like, it's not just working on one person and an older adult. It's literally like everybody is part of multiple systems and multiple historical timelines and, using all of those things. And then some of the things I like that you mentioned, right, that, we do a lot of life review and talking about existential issues with older adults as their time horizon decreases. And I think that's one of the things that I always enjoyed, because I think there's a lot of fruitful work there to be done, and it's deep work too, a lot of times. So
Definitely.
I
Yeah.
think
I
it's
mean, I
fun.
think things get really real when it
Yeah.
comes to life. And and I think there's a lot of gero theory that comes into play when we're
Mhm.
working with people with serious and life-limiting illnesses, that we see, really manifest in real time here as well.
Yeah, yeah. I think that was one of my favorite places to work. And I think that was because of it. You really see a lot of those just stark aging factors come into play when you're working around, you know, mortality.
Yeah. I mean, I think that gero work demands, and especially at end of life, it demands authenticity.
Mm,
So a lot of times we really, and I think the same in rehab settings, right? And disability and rehab settings is that we really have to grapple with our own mortality, our own vulnerabilities
mhm.
in order to do this kind of work. And that's a lot of self-reflection, a lot of self-growth. And it's a constant process.
Yeah, well, that's good to hear because I've been putting them through the ringer in class with reflection on their own identities. So that's good. Speaking of Gero work, so Kim, tell us how you got into this and what makes you stay?
Yeah, I think I was thinking about this for a while. I think my reason for going into Gero hasn't changed since grad school.
Hmm.
And it's evolved and gotten, I think, richer perhaps as I learn more about Gero. But the main impetus really was that I grew up around a lot of older adults because my parents are generally older. So my
Hmm.
parents are both in their 80s or nearing their 80s. And so I've always grown up with older generations around me. And I've always been fascinated by how people adjust to so much change in their life, right?
Mhm.
Technology, advances in science, social changes and such, movements and such too. And so
Yeah.
always been fascinated by people's buoyancy, I guess, right? To still adjust and their resiliency. Um, and then as well, family history is really important, and understanding how family history and socio-historical, political events affect generations in the past and present and future as well.
Mhm.
And so that's always been really fascinating to me as well, about how people navigate life, as their bodies, as their minds, as everything is changing around them and within them.
That's
Um,
that's so true. I think adaptation is like literally synonymous with age. It does things rapidly change towards that time of life for a lot of reasons. I wanted to take a point that you made about the just how things change for people over time and adapt and dial down a little bit to COVID, because I know that you've been working during COVID, not just in the clinic, but also as a psychologist in the world and being an advocate for, peaceful treatment of folk. How has COVID affected your work?
Yeah, I mean, the boxes behind me are a testament. Our unit, I used to work on 2 separate units in the hospital. And because of COVID, we've had to be uprooted 3 times and move our entire unit, our patients, everybody, 3 different times into 3 different units of our hospital, and essentially consolidate 2 units down into one. So we lost a bunch of beds, a bunch of staff as well, and
Mm-hmm.
several patients had to be moved to other nursing homes as well. So it's affected a lot. I think that, so I'll go professionally and then kind of personally.
Okay.
So professionally, it's been really challenging in terms of trying to figure out, this is all new to everybody. So how do I help and be there to support our veterans, our staff, and the family members of our veterans who can't be here, don't have any control of what's happening to their loved one,
Mm-hmm.
and physically can't be here anymore during one of the arguably the most critical times in the person's life, when time is so essential, right? So we're
Yes.
really kind of competing with nature in many ways and competing with time. And it's hard to work with time when we're trying to also maintain safety.
Yeah.
I think the other piece that was really challenging that I think we've all experienced is that there's this constant balance between compassion and safety. And in
Mm-hmm.
this pandemic, safety is always winning out, right?
Yeah.
And so it's really hard to hold on to a person's humanity, our team's humanity, compassion for both ourselves, the veterans, and the decision makers up high, to
Yeah.
understand why this is all happening and how it trickles down to affect our lives in very, very real ways. So it was a struggle. At the same time, as everyone, of course, knows, there was also the social uprising happening at the same time, right? And so that
Yes.
was also challenging to think about how to advocate for those who are the most marginalized or have been the most and continue being the most oppressed.
Mm-hmm.
So, to be honest, I felt so burnt out with all the moves, with all the demands happening within our unit, within our hospital, within our lives here, that I really kind of dove into more of the diversity work and the advocacy work around social justice, because that's where I felt like I had energy to dedicate. And at times I didn't have any more space to hold another person's pain as a
Mm.
psychologist, but I could take all of my anger, all of my frustration, all of my rage around the injustices that have been brewing for centuries, right, but have really come to a head in the past few years, and dedicate that to different causes locally here in the hospital and then broadly too as well.
Yeah.
Um,
I think that's a beautiful way to put it, to talk about like the difficulty of having space for other people's pain during an overwhelming time, but finding ways to yet be so effective in your role is an amazing way to channel it. And for those of you who don't know, I'll be posting the link, but Dr. Hiroto wrote an awesome essay about anti-Asian hate and how she's been experiencing that in the Bay Area, as well as seen it, manifesting in the different spaces that she's at, and just the pure exhaustion, and just sort of throw up your hands and wring them, and what you've been doing with that. But that was great. And do you want to talk a little bit about how you decided to do that and the process for you?
sure. I think, like many people, there has been anger brewing inside of me that I never knew existed to that degree over the past 5 years, if not certainly longer than that. But it really kind of came to fruition in the past 5 years of the last administration. And I think certainly with social uprisings like Black Lives Matter, defund the police, and other examples of systemic oppression, historical oppression over centuries since the founding of our country. And then on top of that, all the racist rhetoric around the coronavirus, and then violent attacks and murders of older Asian adults, especially in the Bay Area and New York City, where my sister lives, as well as in other areas within the US, including at the Atlanta shootings, and the press not covering it, right? And so I think for the first time, so a couple things. So having gone to school in Colorado Springs, as an Asian American woman from West LA, it was a huge culture shock, right? And so I knew that feeling of being targeted, and I knew that feeling of not being anonymous and being exoticized, and not feeling physically safe all the time. But I lost touch with that feeling when I came out to the Bay Area until all this stuff happened. And then I felt that resurgence of this hypervigilance, this fear, this sense of always having to look over my shoulder. And that visceral sensation was, I think, jarring to me, and also was humbling in the sense of people live with this level of vigilance and feeling and surveillance all of their life, right? Yes. More so than not. And how enraging it is. And it was a new level of understanding of what it felt like to truly be oppressed in ways that my privilege has protected me from in the past, I think.
Sure.
And so with the target for older adults and the ageism that has been demonstrated through and through since the coronavirus, and even before then, but really come to a head nowadays, I noticed that there wasn't as much discussion about this within our Gero community, even though we really value older adults and aging, and are pushing against ageism. And so I wrote some stuff on our listserv, and then that got started, and then wrote this other essay as well, which got a lot more attention than I expected, but was a real honor as well.
Yeah. Well, thank you, Kim, for being a voice for people who were marginalized and are marginalized. And, even though I think you're part of that, of a targeted group, I think utilizing the privilege that we have on some level to be able to give a voice to people who can't is really important, and really to call us on the carpet as a profession, right? Like, why aren't we paying more attention to this? Like, where are our advocacy hats when they really are needed? And I think that's sort of what I saw happen on the listserv too, was like, whoa, yes. And I'm humbled by this, and I need to be doing something about it, which I hope was, part of your goal, but it was great. Yeah. So thank you.
Thank you.
So I wanted to ask you a question I've been asking everybody, which is, what are some of the biggest challenges you see for aging, for older adults? They're currently are kind of on the horizon.
Yeah, I appreciate that question, because it challenged me to think more broadly than kind of just day to day.
Yeah.
And my first response is probably one you've heard before, which is ageism. Right? It has been in existence. I was doing a presentation with a colleague of mine, was trying to research, like, when did ageism even start, right? And one of the articles was saying it started with the Industrial Revolution, when people were moving away from homes, and older farmers, older people in agriculture, weren't able to function and maintain the land as well. And so their kids who moved away to be more industrialized jobs had to now take care of their parents. And so they became a burden.
Oh, sure.
And so it's this kind of commodity, it's the aging body becomes a commodity, right?
Yes.
And it gets devalued as a social being. I think that will consistently be a challenge when working with older adults and for older adults in the future as well, because it, I think, prevents people from going into geropsychology, right? Nothing about aging is sexy. Right? Nothing about aging is really that enticing unless you have a personal connection with someone that you see, or that you recognize as experiencing ageism, being oppressed, or being seen as someone who's less than, even though you know that they're an amazing person.
Yeah.
And being misrepresented because of their age. And so I think ageism is a huge detriment. For sure, of course, it's a huge effect, has a huge effect on people's health and longevity.
Yes.
I think that's a major challenge for older adults currently. I think part of it is also our sense of exceptionalism, that I'm not aging, right? This whole anti-aging
Right.
rhetoric that is in cosmetics and birthday, in the Hallmark cards, right? And all these different areas that pop up. And so we see ourselves often as the exception to the rule. And I think so many of us, myself included, have had patients who are in their 80s and 90s saying, I'm not going to go to the senior center, that's for old people.
Right.
Right. And so I think the sense that I'm somehow different than older adults, and it precludes us from including ourselves in a group that is consistently marginalized. Right. And so
Absolutely.
we oppress our future selves, right? We oppress and we marginalize a group that we actually want to belong with, belong
Yeah.
to.
Mhm.
Right.
And I think it also exacerbates age segregation of older adults, right? And my parents live in one of those retirement communities. So, I can't probably speak too loudly, but you segregate out the best agers, according to society, and then segregate out from youngers and all other folk, and you sort of, you're losing that sort of rich connection, but also the reciprocal nature that we need as communities and that you often need to function well. So yeah, I agree with you. It's a big hurt. It needs a lot of work.
Yeah, definitely. Definitely.
Well, then why don't I move to my biggest question? So hopefully, this is the question that we're posing the whole semester, right? Is how can we get to a state of age liberation, and what would that mean for all of us in our different spheres? So, Kim, what does age liberation look like for you, either in your work or in your life?
Yeah, I love this question. It's such a great question to ask. So thank you for instilling it in your course. I think in thinking about what age liberation looks like, it's hard to separate out age from other intersectional identities.
Absolutely.
Um, and so I think in thinking through this question, I think one of them is that aging is really the context in which we understand life, right?
Mm-hmm.
And so I think part of the liberation may come with liberating ourselves from this narrative, like we were just talking about, that with aging comes a reduction in social value.
Mm-hmm.
This assumption that with aging comes functional changes or decline, some of which is true, some of which isn't true. And that the presence of older adults somehow becomes a burden to society.
Mm-hmm.
And that has been shown time and again through COVID with these different hashtags like boomer remover, right?
The
Or
worst.
right, and like other ones around aging older adults should sacrifice themselves for the better of society by
Mhm.
not taking a ventilator, by not taking a hospital bed.
Right.
All these different ways in which they explicitly devalue older adults and not see them as full people. And so I think debunking and then dismantling that narrative somehow
Mm-hmm.
would be part of the liberation piece. I think the other piece is also, humbling ourselves to consider how other cultures and nations and other belief systems view aging and view life experience and view other intersectional aspects of diversity like sexual identity, gender identity expression, right? And so I think that part as well, I think in many ways, US is a pretty arrogant culture.
Yes.
Um, that that we think we do everything best, and sometimes we do really well, but treating older adults is not one of them.
No.
Um, and just like you were saying, having people segregating by age, and then having so few number of hours needed to open like an assisted living facility, right, or a home care,
Mm-hmm.
and then the level of care that is allowed to go by, that allows people to be treated as just bodies is horrific.
Yep.
And I think that is part of also the aging liberation, is the sense that every person should be treated as a full human being, right? And that it's not about equality, but it's about equity. And I think we get those two terms confused so often, understandably. But it's that we need to invest more money in people who have more needs or who never had a chance to have a full life, right? A full life with as much privilege as other people did or have. The other piece, I think, is acknowledging the effects of systemic oppression, systemic racism that are still at play, that affect the lives of past, current, and future generations, right, of older adults. And when I think of the health and the illnesses of the veterans that we serve here, older adults in general, so when I think of the patients I serve here, there's a reason why Black and Brown and Indigenous veterans come in sicker and younger than many other white veterans, right? And so the illness, the chronicity of their illness, the level of debility is a testament to the effects of systemic oppression, systemic racism. And it plays out in their cells, it plays out in their blood, it plays out in their bodies. And to find ways to dismantle that oppression, to dismantle I'll say it, the white supremacy ideology related to power, not so much color, right, and race, but power, and to dismantle those structures that maintain these disparities would also help lift, I think, and deconstruct, right, the structures that maintain ageist beliefs and that keep us restricted and confined and bound to these really ageist belief systems.
I really like that you've talked about intersectionality here and like in age as this sort of background context, because I was just talking with Vanetta Dodson about her work around health inequities across life with older African Americans. And, you know, we had some similar thoughts, like racism is worse over time, particularly when we recycle these socio-historical like hotbeds of anti-Black and racist rhetoric, and then you're re-experiencing. So really age is this back context and cohort are these back contexts, but without that, you don't have the compounding factor. And it makes racism worse, you know, over time, and then the debilitating effects that it can have as you age, as you said. It really is true. If we were age liberated, we would have to be liberated from other things as well, because those structures interact greatly.
Yeah.
Thank you so much, Kim. I appreciate this. This has been a really just fruitful conversation. I've learned a lot. I hope that the students have too. And would you be interested if anybody has any questions? Could I connect them with you?
Sure, of course. Feel free to share my email address. I'm glad to talk further. And thank you for this opportunity to talk with you.
Yeah, thank you.